Hello, and welcome to today's webinar, Innovating Provider Networks to Drive More Cost-Effective Care. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC, or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the handout section at the bottom of your screen. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Dr. David Nace, along with Fran Soisman and Jeff Miklas. Dr. David Nace is the Chief Medical Officer at Innovating. He has over 25 years of executive management experience in large healthcare systems, payer health plans, and leading healthcare provider and health information technology organizations. He has previously served as SVP CMO with United Health Group and VP CMO with Aetna and CMO at McKesson. Dr. Nace earned his medical degree from the University of Pittsburgh. Fran Soisman is the founder and president of Healthcare Management and Transformation Advisory Services, LLC. Prior to this, he was executive vice president at CVS Health Aetna, where he led their government services business portfolio, the growth engine of the company. Jeff Miklas is the executive director at Healthcare Transformation Task Force. Prior to this, he was Executive Vice President, Management Compliance, and General Counsel of the Federation of American Hospitals, a national trade association representing investor-owned hospitals, and a former partner in the Health Law Department of the international law firm of Foley and Lardner, LLP. He holds a JD from the Catholic University of America. At this time, I would like to turn the floor over to our speakers.
Great. Thanks, Monica. This is David Nace. It's so wonderful to be with these two great speakers who I've gotten to know over so much time. Fran, you've had such deep experience in the payer market. I would imagine this issue of provider networks and good provider network management is near and dear to your heart, isn't it?
It is indeed. I mean, when we think about the product, really at the center of the product is the network. If you don't have a viable, competitive network where you've got productive relationships with the provider, you really don't have a good product.
Yeah, absolutely. And everybody's very familiar with Aetna and now CVS Aetna, so very familiar with the company you've been with. Let's also welcome Jeff. Jeff, you've had the wonderful experience of the Healthcare Transformation Task Force thinking about the issue of collaboration. How do payers and providers and consumers start thinking about coming together to really move healthcare to a different place? Maybe you could say a sentence or two about the task force and then how the issue of good management of provider networks is near and dear to the task force.
Sure. Thanks, David, and good to be with you and Fran today. The Healthcare Transformation Task Force is a private sector consortium made up of purchasers, payers, providers, and patient groups, all committed to accelerating the pace of transformation to value-based payment. And you can see with our 4P membership, as we call it, collaboration is at the center of everything we do in value-based care, as it is in networks, as Fran indicated. It probably in value-based care even takes those collaborations to the next level, because you really do need to understand and work as a team, even if you're across different organizations. And so it does start at the core with a very effective network, and then we ask a lot more of the relationship within the network between the payers and the providers through data sharing and other things we'll get into on the call.
So great and wonderful to have both perspectives. Let's get into it. So first, let me start off with this issue that, managing provider data has been a problem for quite some time, hasn't it been, Fran?
That's a softball question. It has. I mean, I think the industry has been challenged with, just something as fundamental as maintaining accurate provider directories, in part because anytime you produce something to paper, by the time it rolls off the printing press, it's already dated. So there's that sort of fundamental challenge, just because you've got changes that occur literally every day, with providers changing locations, or adding providers, or adding new phone numbers, or providers retiring, or dying. So these are life events, and so the practicality of printing directories and evaluating their accuracy, is, I think, really not the proper benchmark going forward. I think we've got to lessen the dependency on the paper directory and rely more on online, and try to get that data as reliable as possible, which is a shared responsibility. It's not 100% owned by the payers, by the plans, because providers are feeding us that information, or feeding the industry that information. It's shared. It's in the provider's best interest to make sure that the patient knows the right address, and that address is provided accurately. There are human errors. When you're loading the data could be transposition errors. They occur. So, CMS has set very high expectations, as they should. They are all about protecting the beneficiary, and I think there's a difference between intentional errors of sloppiness versus unintended errors. So there's got to be some tolerance for just human errors. But it is a challenge. It is a challenge. I think the industry has demonstrated they're taking this very seriously. Everyone, I think without exception, has put tremendous amounts of resources and technology to work to try to, really try to solve this particular challenge.
That's great points. And I still remember dealing with this 30 years ago, and it's probably more so of an issue as we move into value-based payments. Jeff, you operate a very interesting collaborative of payers and providers and consumers. And each of them, the payers, the providers, they're running businesses. How important is this concept of data and good data management to running their business?
Well, it's at the core of everything that we do with value-based arrangements, and really it needs to be a two-way street between the payer and the provider, kind of giving information back and forth. Unfortunately, I think one of the factors on why the transformation is not happening more quickly is probably related to legacy systems on both the payer and the provider side. And so when we talk about core functionality like provider directories, that's been an issue for a long time. But as we talk about exchanging actuarial data, or looking at some lists of high-risk patients and things that are just at that next level in value-based care, the systems need to play catch up a lot. And I think what we see in the marketplace is that there are disrupting organizations that are coming in that can partner with value-based stakeholders, either on the payer side or the provider side, that can help manage that a bit better and add some utility to the different systems available to the core participants.
Actually, that's great, and it's great dive into this move to transforming the industry into value-based care. Fran, here's this survey that Accenture did around what are the key enablers to helping payers achieve their business goal. Does this line up correct to you? And maybe you could walk us through a case or an example or two from your experience of where data is a key enabler and one of these key enablers for the business.
Well, I think a lot of payers have that the journey started to be more member-centric, patient-centric several years ago, and using using the digital transformation as a means to try to solve the challenge by putting the patient in the center of everything that we do, working collaboratively with providers, providing tools to providers and to consumers to get better outcomes, administrative simplification, so that the providers can spend more time with the patients, less time on administrative paperwork and so forth. And I think good progress has been made on all of those fronts, but we have legacy products. I mean, with the exception of maybe some of the newer competitors that have come onto the scene in the last couple of years, many of the blues and the national carriers have been around for a long, long time, and they have, generations of products. Oftentimes not retiring many of them. It's just an additive process you have to keep supporting, and it just adds to the complexity for all. The plans it's complicated for the plans, it's costly, and it's certainly administratively complex for providers because they've got to know how to deal with all of these different, combinations of plans, of products and so forth. So, but I do think that there is. I think in large part the industry is in lockstep for simplification, putting the member in the center, using technology to improve the experience. At the same time, not every consumer wants to use their smartphone. They still want that personal touch, so you can't force it on everyone. You've got to respect the fact that people have their preferences, so you've got to offer them the choices. But I think working with the provider community, particularly as we shift away from fee for service to value-based care, I think is where we're going to gain the greatest benefits on all fronts: administrative simplification, improvement in quality of outcomes, reducing cost, improving the member experience, member satisfaction, and frankly, improving the provider's satisfaction. So I think there's a lot to be gained on the value-based side, and I'm sure Jeff can add to that.
Jeff, do you agree? Sounds like Jeff's on mute. If we can get him to unmute his mic.
There we go. Thank you, David. I appreciate that. Sorry about that. I was going to say exactly the point that I wanted to make carries on here. I'm disappointed to see how low on the survey here, working closely with ecosystem partners, scored. Because in the value-based world, and in the 6 years the task force has been in existence, it sounds soft and maybe even a little touchy-feely, but it starts with relationship building. And you have to have an open dialogue between the payers and the providers and even the purchasers who are buying this product in the commercial market. And it's different than the normal posturing around contracting or some other maybe more adversarial type communications. The task force has had significant uptake on a resource it developed a few years ago that we call the Value Partnership Evaluation Tool. It's a different mindset, but it's this idea of being able to evaluate an organization that you want to partner with and assess their strengths and weaknesses. It can also be used to benchmark your own status and progress. And then it's meant to be shared between the partners, which is a little bit more open and collaborative than maybe the traditional relationship has been. But it's really critically important to make sure everyone is on the same page from a mission perspective, and then also has the operational game plan to be successful, because it is a challenging environment in the value-based care world.
Yeah, and it could be, David.
I
would agree with Jeff completely. It could be that the survey may have been more heavily weighted towards a commercial, and less towards Medicare Advantage and managed Medicaid, because I think had it been surveyed, towards that slant, that number would have been much higher.
Yeah, no, that makes a lot of sense. Fran, given your deep experience at Aetna and prior payer experience, we talk about the data not being correct or not being timely. Walk us through why that is. There's a lot of different systems that populate data in relationship to providers, aren't there?
There is, and again, depending on the segment, you may be dependent on a third party to get the data, dependent on CMS for verification of eligibility, for example, or the state for managed Medicaid. So it's not necessarily, you have 100% control of certain functions when you're dealing with certain segments, or even for the employee, the commercial market, you still are dependent on that employer providing information about adds and deletes on a timely basis to be able to therefore provide that service to that new member, or to execute the benefits for a member that's terminated properly and avoid a situation where you paid claims and then have to recapture it because the member truly was terminated 30 days ago. And nobody likes that situation if you got to try to recapture, recover monies from a provider who in good faith delivered the care. They thought that member was eligible. Well, we were alerted late. So there's got to be a spirit of working together, that we're in it together, and it's in everyone's best interest to understand the unintended consequences of when we're not in lockstep. And starting with enrollment and eligibility, very basic things. Bad things happen, when you're not in lockstep. We talked about the provider directory. Claims administration, my gosh, you get cash flow issues when claims are delayed. You get, the actuaries, it can throw their reserve models out of whack, and all of a sudden your internal financial confidence can be shaken because you're getting your models are affected potentially if it's a significant enough event. Member services, you can't give a member a great experience, and that's what it's all about. If the data is not accurate or it's not timely, they're going to feel it. And the whole idea of this is that you don't want them to have a bad experience. You don't want them to see the administrative hiccup. Things are going to happen, but you don't want the member to actually have to experience it. So, I could give you hundreds of examples, and I think that things are going to happen. It's a question of how quickly you can remedy them. And hopefully they're not systemic problems, because then that's a really bad day.
So you've walked us through a lot of these different systems and places that things can go wrong or not be timely. Jeff, I would imagine this is really important to get right if you're going to do what the mission of your organization has been, is moving the American healthcare system to a value-based system.
Mm-hmm. Yeah, I would say, again, just it starts with the trust, and that's why if you have a good relationship and then you encounter one of those problems that Fran's identifying, the people are committed to solving that and working together and not pointing the finger at each other. And I think that we've seen in our members' experience that the opportunity to think through how you handle those situations up front is critically important. I think some of the things that you have listed here on this slide, really resonate with our members as they move toward value, and some of them are even more important than ever. I think, again, just focusing on something I had said before, the provider data and the ability to share kind of advanced data sources between the payer and the provider. And it's not just one way. Really, the payers are looking for information back too, some of the clinical information related to encounters and things of that nature. So in many ways, that's really one of the most challenging issues we face, is under the data management and the ability to share among stakeholders who may not be used to that level of collaboration in earlier models.
Yeah, and that collaboration is going to be important, and we're going to get into that a little bit more. Fran, I worked for payers and worked for McKesson for a decade, serving technology, serving payers as well. This issue of high-performing providers is even yet another layer that we need to think about, right? Not just getting the directory correct, not just getting the information correct. What is the importance of first of all, what is a high-performing provider network from your vantage point, and why is that important as a holy grail to eventually get to?
Well, you hit on a really important point. I mean, we we can't help but make things complicated, can we? Um, Good intentions, and it's sort of to get to the least common denominator of getting the best combination of the right benefits at the right cost with the best network, all in the name of giving the member a great experience and giving them value and a competitive price, and preferably a sustainable competitive price. And I've argued with some colleagues in the past that to really provide affordability, we actually have to go backwards. We have to lower cost. We can't just manage the trend. We actually got to lower cost, because I think we've probably largely gone beyond the point of affordability for most people. Which is why we see high deductibles and so forth, just to find ways to lower premium, but through benefit reductions. But to get to your question, um, high performance networks are ways of essentially paring down the choices, but doing it through a selection of providers who have measurable, uh, better outcomes, who buy into the notion of um, largely value based, or some form of, it doesn't necessarily have to be a global cap, full risk arrangement. It could be something in between, a gain share model and a global cap, but are willing to take responsibility for outcomes. And while there's some perceptions that they're willing to take a lower reimbursement rate, that often isn't the case. At least that's not been my experience. It has more to do with their buy-in to what we're trying to achieve together to improve the quality of care. So you could have centers of excellence. You could reduce the number of hospitals that are available, but in exchange, you're getting, a, in the end, avoiding access to providers that have been less effective in utilization management, that could be higher cost for a variety of reasons, and you're doing it based on, um, risk-adjusted data. So it's backed with science, which is important. So it's not arbitrary and capricious, and um, and you're doing it through a process. You're giving providers a chance to get there before you make that determination of what it takes to qualify for that network. And usually it's done on a segment by segment basis. So it could be your high performance for Medicare Advantage, but you still can be in the PPO for commercial, or still playing managed Medicaid.
No, that makes a lot of sense. And I love what you said before, is we sure do make things complicated. Well, what I would love to do is to go ahead and check in with our audience, and just take this quick poll. Monica, can you run this poll for us?
Thank you. The poll will be on the right side of your screen next to the slide deck. Please make sure you're not in full screen mode so you can participate in the poll, and we certainly appreciate your feedback. The poll reads, what are the key challenges you face while building provider networks? And we have 4 choices: inaccurate provider directories, siloed point applications, insufficient provider engagement during contracting or credentialing, etc., or infrequent updates to provider information. So of those 4 choices, you can choose as many as apply. Again, what are the key challenges you face while building provider networks? So go ahead and make your choices, and I will turn it back to our speakers.
Awesome. Well, we're running that poll, and we'll check in just a few minutes when that's done. Jeff, you've got a lot of payers that you've brought together, and I love that quote in the last slide by John Glacier about, value-based care, everybody wins or everybody loses together. So there are some key questions for payers. Do you think these are the right questions we're looking at here, and how has COVID started to raise some additional issues?
I'm happy to answer that question. I would like to just make one comment on the slide that Fran was commenting on, because I think he nailed it. And I think on top of that, though, what we're seeing in high-performing networks now is really around that bullet point you had on the slide around care coordination. And what we're seeing there is the understanding, again, of the capacities of either the payer or the provider, because whoever's best situated to kind of do the care coordination should really be the lead there, but needs the partnership. And in the high-performing network, what we're hearing from our members these days is going past kind of the traditional outcomes and actually speaking with individual providers. Most physicians I've met believe they're above average, and that can't really be the case on a bell curve. So actually sharing their outcomes and their performance is really important. But the other one that's really kind of gaining steam is care transitions, right? So how do you actually move a patient through the system and quarterback them and work well with others so that you're just not kind of focusing on your piece of the pie and not thinking more holistically about the care the patient's receiving. I think with regard to the questions for payers, I think the evaluation and maintenance of that kind of high-performing network is critical. I think the one thing we've seen at the task force is an understanding from the payers that they need to have their networks be broad enough to kind of provide value in that product, but not every provider that they need to have in the network to kind of pursue that may be at the same level of others. They may have more room for growth and development. And so while there may be kind of a geographic need to include a particular provider or a group of providers in the network, I think the ability to move those folks forward and make sure they just don't stand pat where they are, that they actually move in the direction of providing a more valuable product is really important. And a lot of the current conversations we're having at the task force are around those evaluation criteria. What are the success metrics that we're aiming to kind of achieve in value-based arrangements? And then how can we take those broader principles and apply them kind of through individual evaluations?
Makes sense. Well, let's go ahead. I see the poll results are in. Let's pull them up and take a look. Interesting results. Fran, what do you think of these results?
I'm not actually seeing them.
So we've got 24% inaccurate provider directories, 22% siloed applications, 19% insufficient provider engagement during contracting and recredentialing, obviously, and 34% infrequent updates to provider information. Sounds like it's equally distributed.
Yeah, I'm a little surprised at the 34% on the infrequent updates to provider information. That one is a little surprising. I wouldn't have expected it to be that high. We didn't give them the choice of adding a, other. Be interesting if we did, if there would be a higher number in the other category. I would have expected the siloed to be much higher. I had written down a number before we went on, and I was way off. So.
Yeah, no, that's a great point, and that really raises us to our next point. But it's great to see the audience weigh in here. I'm gonna, Jeff, you haven't seen this. Fran's worked with us here at Innovator, and we are all about data. How do you connect with all these different data sources? How do you aggregate it, bring it together in real time, enrich it, and create a unified provider data? A model, not data that you have to go query different systems, not interfacing different systems. Look at all the people here that you can use that data. If the things were more unified around provider data and more real time, what impact do you think that would have amongst these various ecosystem members from a payer perspective?
Well, I think it's all about the investment, and that's actually how you build those trust relationships, is that you bring things to the table that make everyone better. And so this type of uniform provider data platform for the opportunity for people across a system to use and not, to your point, have to go into different systems and kind of interface them, I think is critically important. And I think we see that too kind of in networks where like-minded organizations are working together. Fran's former organization, which is a member of the task force, they have a huge initiative with regard to joint ventures in the value-based care space. And so they think about themselves as if they're an integrated organization, even though they're really part provider, part Aetna. So that idea that you could have something here that people could be leveraged, and so that all the people across the care continuum can tap in and benefit from it is critically important. And I think then it's like anything else in transformation, it's continued iteration. What can we do to continue to make it better? What's worthy of the investment so that we get our systems to where they need to be to support high quality patient care in the 21st century?
Makes sense. And I think someone asked a question in the audience, what is a siloed point application? Historically, Fran, people have built applications for each one of these ecosystem players, right? They've all had their own data systems. This sort of approach, being able to activate the data in their workflow, would help to provide more of a capability of working together, I would think.
Yeah, I think so. And with just networks have changed. The acquisition of providers, has changed by either health systems or payers, has changed that whole dynamic. So I think it has to be looked at differently as well. I was also, going to suggest that there's greater specialization that's occurring within networks. Initially, the word that rolled off my tongue was fragmentation, but that sounded negative, and it shouldn't be viewed as a negative. It's just, primary care is getting more and more specialized into home-based primary care versus virtual primary care versus office primary care, and how you use telemonitoring, for example, to support home care, home primary care. It's a very dynamic process, and it means that the network configurations, the management of the data, all of that has to be very, very fluid, and it has to be able to really, stay a step or two ahead of it, so that what you need in the way of data to be able to get, to be able to not compromise the outcomes, just because you've gone specialization in one of these areas. I think that's, one of the takeaways, I think, from this conversation. If people aren't thinking about it that way, they should be.
Well, let's break this down into a couple of steps here, just for the conversation. We see in this bottom bar the ability to bring data together from all these sources, and I always say unify it. A second step would be able to do analytics, right, to make insights from that data. Otherwise, you have what people often call a data swamp. The third would be then engaging these members of the ecosystem, right, and getting the provider engaged, so that they actually feel like it's useful and actionable information. And then coming back to really helping to go back to what we started out, which is being effective in value-based care arrangements. So I'm going to actually ask Jeff this question because Fran's had a little bit of a head start on this, working with us, talking about data. What do you think the importance of bringing all this data together would be for value-based care, Jeff?
Well, I think, again, we need to understand, especially with the complexity of some of the payment models that are being pursued and the drive toward, capitated arrangements and better actuarial understanding of populations. All of this data needs to kind of go into a system that helps people think more clearly about that. The one observation I'll make about my time at the task force is to watch what I would call the cross-pollination between payers and providers. There are a number of people we work closely with that are in payer organizations now that have provider backgrounds and vice versa. And so they have a better understanding across kind of the network now, across the system, of what are the needs. And so, obviously accurate and timely and actionable data is really important. I think the other observation I'll make about this slide and the prior slide is just, we hear a lot in the value space about buy or build, right? And the idea that there are dynamic platforms that both, that both providers and payers can purchase for use is critically important, because it's designed with both of their interests in mind, as opposed to, legacy systems that really kind of had that one perspective. And then on top of that, though, I think, from somebody who's worked with hospitals a lot in my life, the idea of buying an EHR that day two you see the limitations in and really hard to fix and keep updated is a frustrating opportunity, especially given the price tag on some of those. And so the idea of kind of having the data platforms continue to grow with AI, with other opportunities to build out and keeping it kind of on point and up to date and continually innovating it's critical for the success of value-based arrangements.
Now, Fran, you've been involved with value-based arrangements and the use of data to help manage them in the past, but it's all about analytics, isn't it? Isn't that what the data is for?
Well, in large part it is. I mean, first generation risk arrangements were really economically driven, and which is why they failed. So we've come a long way in terms of making this multiple dimensions to really define what is the end result we're looking to achieve, and that is to improve the quality of life of the member patient that we have the privilege of serving, and how do you best do that? Capturing the right data at the right time and then putting it in the hands of the people that can make the difference, whether that is the physician or the PA or the patient, right? I mean, because the patient has some accountability here to manage his or her health, whether that's through medication adherence, or proper diet, exercise, what have you. So we're all in it together, and but having the data, knowing it's reliable, and then being able to manage and measure the changes, and then to your point, analytics can then be a predictor, right? Because then we get into predictive analytics, which has even greater value if it's reliable, right? I think that's where you can really make a difference, if you can intervene before someone really is looking at a life-threatening situation. So, but it's steps to get there. I mean, you can rush it, but you're not going to get the right outcome.
And Jeff, have you heard where the data's not good or the reimbursement is based on faulty analytics? Have you heard from the provider community that they get frustrated from that perspective?
Absolutely. I mean, but one, they recognize it's kind of still an evolving space and there's going to be room for errors, but that doesn't mean they're any less frustrated when it does happen. It is real. I think it's happened in some of the Medicare models run by the Center for Medicare and Medicaid Innovation, where you have huge uptake and the impact is wide on that. But I also think it's a challenge when you do find faulty data to continue to develop the confidence to get to those advanced risk models that many policymakers and business leaders would like to really see us get to. And so the predictive modeling piece that Fran mentioned kind of takes on a few different faces in that regard. And without good data to be able to reliably predict, the performance of a population, over a year or 3 years, it's really hard to get to those advanced risk arrangements where it really is true risk sharing. And frankly, if we could get in that direction with data, then we could start to reduce cost in some other areas with infrastructure and get away from claims payment and some of the other things that, that absolutely add cost to the system. And so data will just continue to be key, and if it's not reliable, then it's a step backward.
Fran, your perspective on engaging providers and keeping them engaged around these new value-based arrangements based on data?
Well, hopefully you won't have to motivate them. Hopefully, if you got the right relationships and the right value-based arrangements, they'll naturally be engaged, right? Because the consequences of them not being engaged with downside risk, it's going to hit them in the wallet more positively when they can demonstrate that they are improving the outcomes of their patient population through their intervention, through lifestyle changes. Then they're rewarded. And the industry, that's exactly what the industry is looking to achieve, because when they retain their patients, when they've got satisfied patients, there's a higher likelihood that the patient, particularly the individuals, right, those who are making their health plan decisions as opposed to those who are involved in group health insurance, where their employer is making that decision for them. But the individuals, they're likely to stay with their health plan. So we're talking about MA and Medicaid, because they're gonna see that relationship of the provider and the plan as one and the same, and stay, as opposed to changing every open enrollment year if they're just not getting the results that they expected. So I think there's a lot to be gained by these value-based arrangements, and they shouldn't need further motivation than what the way those models are structured.
Yeah, and I know it's near and dear to your heart around the issue of how do you then create the right incentives to pay the provider.
Yeah, I mean, they have to obviously measurable. They've got to be fair in terms of reasonable goals as far as improvements. I mean, we're in it together in terms of, like, for example, STARS measures. It's sort of, shoot the arrow and paint the target. We don't know from one year to the next what's going to really constitute 4-star, 5 stars with all the different measures, because it's a crapshoot, right? We don't know. We, the industry, don't know, because you can get swings in the data, and it can move the needle up or down. So you have to be careful about putting too much stock on that, because it could be demoralizing if they actually get good improvement, but not enough to then move it to 4.5 stars. And that's really what plans need to be striving for anyway, is, in my opinion, I should say. 4 stars is good, but 4.5 strategically is where you want to be in the MA space. I don't want to focus exclusively on MA, but it's one of the more developed programs end to end, and in terms of incentives with caps and HEDIS and stars. Providers get it. Look, providers, David, this, you're a physician. Providers want to make a difference in their patients' lives. They go to the ends of the earth to do the right things, and sometimes we payers get in their way. Well intended, got a set of rules that we have to follow too. But I think we're all well intended. Sometimes two well intended organizations can be in conflict from time to time.
No, absolutely. So let me just summarize, and I want to come back to Jeff with a question. So we talked about at the very bottom here the issue of bringing data together, making sure it's high quality data, unifying that data, not having all these different systems manage the data on their own, let alone having people enter data in all these different systems, bringing that data together, doing some analytics on that data, and then, being able to use it for, being able to track performance of these contractual relationships, having a single view of everything about a provider. But then this issue of workflow. Jeff, I want you to talk about this. We hear a lot about in workflow. Providers don't want to go to a portal. They don't want to go out of workflow. They don't want to log into multiple systems. Share a little bit about what you've been hearing from folks when they talk about this issue around being in their workflow.
Boy, it's a challenging one, David. I think that on one hand, we talk about clinical pathways to help to kind of standardize care, and kind of make sure that there's equal access to high quality care. But I think that the idea that it's still so individualized that we need to capture the data, make sure that we are connecting the patient with the right service and the right provider at the right time, still makes it really critical. And so the one thing we definitely hear is that those folks who are running like accountable care organizations and things, one of the biggest challenges is to make sure that the participants in that organization are having a consistent workflow and are actually taking advantage of the data that's available to them. I mean, we just talked about how problematic the data has been, and now we're in a situation where we have more access to it, but there's providers who aren't using it as much. So there is all this thought now about how we develop analytics to measure individual providers beyond just the outcomes. How else are they playing with the team, as it were, on a coordinated care arrangement. And in that regard, I'll say on the provider incentives piece, I think one of the biggest challenges to date in the value movement is how do we effectively engage specialists? We have spent a lot of time around primary care. We've with success. We've spent time with primary care and behavioral health integration with less success, but some promising ideas there. It's still trying to incentivize and kind of capture the attention of the specialists and have them be effective partners in the value model is really important. And so I know a lot of the task force members talk about trying to come up with that meaningful data set that produces a report that helps them see the opportunities that are available to them in value-based care.
Great. So this is a fabulous discussion. I'd like to quickly just check in with our audience just to see what they've done to date around this sort of approach. You know, how do they unify data? Monica, can you run the next poll?
Thank you. Yes, the next poll is appearing on the right side of your screen. Again, to participate, please make sure you're not in full screen mode so that you can participate in the poll. And again, we do appreciate your participation and value your feedback. And that poll reads, how are you managing your provider networks? And we have three choices: using in-house technology, or vendor technology, but looking for an integrated solution, or we have an integrated solution we've built in-house and we're not looking for a change. So go ahead and choose from these answers. Again, how are you managing your provider networks? And I'll turn it back to our speakers.
Great. Thanks, Monica. Fran, you were biting on the chop to make a comment there, so go ahead. It's all yours.
Well, you know, I was just going to pick up on one of the important points that Jeff made. Again, we tend to broad brush the conversation around networks as if they're one-dimensional, and we know that networks look different, and whether they're provider sponsored networks or a Kaiser or Geisinger UPMC type network versus independent physicians, and they have to be managed differently, because of the way they're structured. And the incentives is a great example. So if incentives don't flow down to the providers that are actually interacting with the patient, rendering the care, they're not likely to be as effective. So chances are money's being left on the table, so to speak, because they're not achieving all of the goals where they could have achieved even more in upside bonuses, if you will, because if the providers aren't personally participating in that bonus sharing, not likely to get as much of an improvement. And I'm generalizing. I mean, there are exceptions to that rule, but what I've seen historically is it just doesn't get quite the same bang for the buck as models where providers are individually rewarded for their performance relative to the improvement in the outcomes.
That's a great point, and it may mean if we can finally resolve this problem of poor data quality, isolated silos of provider data not being timely, updated, not being unified, we might finally be able to move value-based care forward. Let's take a look and see how far along our audience is. Monica, can you pull up the poll results? So Fran, I don't know if you can see these results, but I'll read them for you just in case. 53% are using an in-house technology. 34% are using a vendor technology, but they're looking for an integrated solution. So my assumption is that first bucket isn't integrated. They're just using in-house technologies, for all those different silos. The next result was 13%. We have an integrated solution we built in-house, and we're not looking for a change. So 13% seem to be having gotten to where they need to be. What do you guys think?
Not surprised to see 50% of people that kind of are still status quo. I think that this is a wave that's just starting to crest. I think over the next 5 years, as the prevalence of value-based payment and the reality of it comes forward, I think there will be more investment. And as people just define their investments to make this transformation, I think data sources and integrated solutions are going to be a critical part of that.
Yeah, I would agree with Jeff. I think that, again, a lot of organizations look at this on a segment by segment basis, and their data warehouses are aligned to their segments. So they've got a data warehouse for managed Medicaid, a data warehouse for their commercial business and Medicare, et cetera. So I wouldn't be a bit surprised if they have strategies that they may not have a unified strategy for all of their data warehouse management. They may outsource some of it, insource some of it, because they may be further along in their value-based strategies with a particular segment than others, and therefore their needs for data management are greater. So that
makes a lot of sense. So let's do a quick review, and we've got a ton of questions in here. I'm hoping we can get a few of them in here. So just to summarize, I think the sort of things we talked about starting at the bottom here is being able to pull together data from all these different sources, and we have a question about that we'll get to create a single source of truth across all these different systems, and then having to be able to perform analytics on that high quality data and then get this 360-degree view of a provider to help with the relationship. And then also the workflow. Jeff, you made some great points about the complexities of being in workflow and also the importance of that. So with that said, I just want to share before we open it up for these questions, kind of what we're doing here at Innovating. And Fran, you've been involved with us a bit in terms of how we're thinking about the ecosystem. Maybe you can make a comment on what the future might be like if we could bring all of these ecosystems together, payers, providers, consumers, maybe even others.
What a wonderful world it would be, right? No, it's the greater the collaboration, the greater the sharing, the more timely the sharing. I think that it'll be an exponential improvement in outcomes, quality, and reduced costs, and probably the elimination of unnecessary cost as well. So I see nothing but positive upside as these are worked through. I don't see any downside at all.
And Jeff, you mentioned it very early in this webinar about the issue of an ecosystem. Shed some light here in your perspective of what the future could look like.
Well, I think it just, it's more, we can call it coordination, collaboration, integration. It's going to take different names depending on the structure of organizations, but it's going to take people kind of getting out of their comfort zone and business as usual and really looking to collaborate and coordinate. And I think that that's true just from an operational standpoint, but now you look at the focus in the country on, addressing health disparities and tackling some of the systems of oppression that have been available in our care, and the greater ability to address social needs and social risk factors and social determinants on health. And it just means that there just needs to be more active engagement between stakeholders who are working together to understand their communities, the needs of those communities, and then design products and services that can address those. And there is no one size fits all. It really takes dialogue. And so by the ecosystem, we really mean like-minded people that can come to some set of broad but consistent goals and are willing to dialogue on how you get there.
That makes a lot of sense. Well, let's move into these questions because we've got literally, there must be 100 here. So I'll tee them up. We have a question from Craig Ratner, who I believe I know. The first question I have here is aimed at Fran. Fran, how will you accommodate current Medicare Advantage beneficiaries, i.e. my 82-year-old mother, who are particularly hesitant to transition from a paper-based provider directory to online network information?
We may never be able to do that, but we may also have to reset expectations about the the life cycle of that paper directory in terms of its accuracy, so that people can't expect that if they go to it a month later and think that it's still going to be 100% reliable. It's not the right expectation.
Yep, that makes sense. Jeff, this is from another audience member. I was more than a little surprised that last year, NACO announced that their ACOs were going to save CMS approximately $250 million over 10 years. Given that $25 million per year is 4/1,000th of 1% of the CMS budget, are we having some difficulty in demonstrating cost savings from value-based care?
Well, I'll say this, it is a journey, and I think it's headed in the right direction. And there are additional policy levers, I think, over time that the federal government and the state governments could pull to increase those savings. I think the reality in the early on the public policy side of this, the early remarks out of some of the new leaders at the Center for Medicare and Medicaid Innovation are actually less focused on cost saving and better value in the product and thinking about quality in a different way. Because they have found it very difficult over the first 10 years of the Innovation Center. They've tested 54 models and only 4 have qualified under the statutory authority for expansion. And so clearly that bar has been set at very high level, but the alternative of staying entrenched in fee-for-service isn't a good one either. So the NACOS numbers are promising, but the scale needs to be there, and you get into a whole thing about whether they're voluntary models or mandatory models. There's all kinds of levers that could be pushed to actually increase performance, which would drive more cost effectiveness. But it's not intended to be kind of the output of the managed care environment from the 1990s either. We need to really think about improvement and how that makes a valuable product, even if the cost is relatively the same.
Great. Yep, no, that's great. Just want to fit in one last question, and this one is for Fran. Would love to know, as more payers commit to value-based payments, what are the limitations in existing technologies to truly understand how they can meet their goals? So it's a summary of everything we've talked about, but the top priorities from your perspective.
That's a great question. I'm not sure who asked that, but that's a great question. I think that the limitations are depending on the plan. I mean, some of these, are legacy platforms that probably need to be phased out, retired, replaced with more agile platforms that have the ability to communicate via cloud technology, real time. I also think that Jeff touched on looking at this more holistically, so it's not just the pure clinical side. We got to look at this holistically. We got to look at all of the components need to come together so that we're looking at the patient holistically. How can we best affect this patient's life to get the best possible outcome, whether it's pure medical, behavioral, or social.
Makes sense. Well, listen, this concludes the webinar, but I really want to thank you, Fran, and you, Jeff, for taking your time, and also Monica for helping to support us in this webinar, and most importantly, all of the audience members who were able to participate. And we will forward these slides, and we will also be following up with maybe some answers to the myriad of questions we have here. So this has been a great webinar. Fran, thanks for joining.
My pleasure.
And Jeff, many thanks to you as well.
I appreciate the invitation.
Great. And with that, this concludes the webinar.
Thank you. Thank you for the great presentation and for sharing your thoughts, and thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you, and enjoy the rest of the day.